Lady, before we get to this afternoon's witness, there's one procedural matter that I'd just like to clarify, if that's okay. On Friday, the 19th of January, the inquiry heard evidence from Dr. Jim McMiniman, as your Ladyship will recall, who had previously provided the inquiry with a witness statement and accompanying documentation, including some WhatsApp messages. An extract of those WhatsApp messages was put to Jason Leach on Tuesday, the 23rd of January, and subsequently published on the inquiry's website the same day. The specific extract is from INQ 000268025. In the published extract, the formatting of the messages may make it appear as though Dr. McMiniman is agreeing to a suggested deletion of WhatsApp messages. Our interpretation is that this is not the case. Dr. McMiniman was replying to another message earlier in the chain of correspondence not shown in the extracted text. The formatting of this WhatsApp message for presentation in evidence makes the message appear chronologically and does not illustrate direct responses to other messages out of sequence in the chain of correspondence. For the avoidance of doubt, I wish to make clear that the evidence shows that Dr. McMiniman did not delete any messages. It is in fact Dr. McMiniman who provided the inquiry with the WhatsApp messages contained within that document via his employer, Public Health Scotland.
Thank you very much.
Thank you, Lady. The witness this afternoon is Ms. Jean Freeman, OBE.
I swear by Almighty God
that the evidence I shall give
that the evidence I shall give
shall be the truth,
shall be the truth,
the whole truth,
the whole truth,
and nothing but the truth.
and nothing but the truth.
Thank you very much.
I hope we haven't kept you waiting too long, Ms. Freeman.
Not at all, my lady.
You are Jean Freeman.
I am.
You have helpfully provided some statements to this module of the inquiry, in particular a witness statement dated the 16th of November 2023 under reference INQ 000273984. Is that your statement?
It is.
Have you signed that statement?
I have.
Do the contents of the statement remain true and accurate as far as you're concerned?
They do.
You have also provided a further witness statement to this module of the inquiry, which is dated the 21st of November 2023 under INQ 000347982. Is that your further statement?
It is.
Have you signed that statement?
Yes.
And do the contents of that statement remain true and accurate as far as you're concerned?
They do.
You previously gave evidence to Module 1, as I understand.
I did.
You're currently the Dean of Strategic Community Engagement and Economic Development at the University of Glasgow.
I am.
You've held that role since February 2022.
Yes.
From June 2018 until May 2021, you held the post of Cabinet Secretary for Health and Sport within the Scottish Government.
I did.
You left that role in May 2021 prior to the Scottish parliamentary election, in which you did not stand. Is that
That's
correct?
correct.
Prior to holding that role, you were the Minister for Social Security within the Scottish Government between the 18th of May 2016 and the 26th of June 2018.
I was.
Your current post is a post in academia.
Yes.
As Cabinet Secretary for Health and Sport, your responsibilities included the NHS and its performance, national clinical strategy, carers and adult care and support. Is that correct?
That's correct.
Thank you. I'd like to ask you some questions about your use of informal communications during the course of the pandemic and also your retention of them. The inquiry has seen on a number of occasions a table that was helpfully produced by the Scottish Government indicating the position with regard to usage and retention of a number of different things, including informal messaging. This is dated from October of this year. As at that time, the position communicated to us was that the Scottish Government, as it states there, understood that some WhatsApp and text messages had been retained, and the Scottish Government was currently clarifying the volume, but did not expect it to be large. They indicated that you had been part of a WhatsApp group of Cabinet Secretaries for Health of the 4 nations to facilitate meeting running, and they confirmed to us that no other WhatsApp groups or that you had been not part of any other WhatsApp groups or other informal messaging with key decision makers. Now, obviously the position has moved on somewhat, we'll get into that in a moment, but as at October of this year, was that the position that you held as communicated to us by the Scottish Government?
Yes, it was. I was always clear and knew that the only WhatsApp group I was a member of was with the other health secretaries, the 4 Nations group. But then subsequently, I checked the rest of the WhatsApp messages I could access and, as you know, disclosed all of those to the inquiry.
Thank you. Yes, we'll have a little look in a moment at the variety of types of messages with whom and that sort of thing. But as at October of this year, this was the position, and then subsequent to that, you managed to find a number of messages which you've provided to us. Is that broadly correct? As far as your phone usage is concerned, you tell us, I think, that you used a Scottish Parliament-issued phone for government business, which you handed back to the Parliament when you left in May 2021. Is that right?
That's correct.
Why did you not use a Scottish Government-issued phone?
I didn't feel there was a need to. I didn't really want to have 2 phones running, and the number I had for the Scottish Parliament phone was actually the mobile phone number I have had, I think, since 1993, when I got a mobile phone after my father died. And it was a number known to family and friends as well as anyone else. And so I wanted to retain the number, and I didn't want to have more than 1 mobile phone that I was using.
I see. And our understanding from your statements is that the Scottish Parliament phone that you use was connected to the Scottish Government secure server for the retention of Scottish Government email to the Scot Electronic Records Management System. Is that right?
That would be the Scottish Government issued tablet that I used. And the mobile phone emails were MSP emails, so that was for the purpose of conducting my constituency business. But the tablet was a Scottish Government issued tablet that was then connected into the Scottish Government system. So if I used that for any emails, they were recorded into the Scottish Government system.
And so as far as email usage is concerned, is it the case that as far as the conduct of your Scottish Government business, you used the tablet for those emails, or were other devices used for emails?
No, occasionally the phone would be a copy. So an email might be sent to me on Scottish Government business through the tablet and copied to the mobile phone, but it was already in the tablet. And that would be emails coming predominantly from my government private office.
And as I understand the position, that would mean if it came via the tablet, it would already that email would already be recorded automatically within the Scottish Government system. Thank you. You say in your witness statement dated the 21st of November, paragraph 9, my Scottish Parliament phone was returned to them when I demitted office, and while the WhatsApp and text messages I have noted at question 13 are retained on what is now my personal phone, I do not have access to those with Gregor Smith, Jason Leach, or to the few text messages between me and Nicola Sturgeon. We'll get to in a minute. There's a big list, we won't go through all of them, of people with whom you exchange messages of some sort during the course of the pandemic. But it appears from that statement, as I understand it, that some messages which would have been exchanged on your Scottish Parliament phone somehow made their way onto your personal phone, but some did not. Is that correct?
So the ones that did not because, as you know, both Dr. Smith and Professor Leach had, I think, auto-delete or took steps to delete messages. And so I did not have those on my phone. What was now my personal phone, it still had the same phone number. And so when I purchased that, everything was downloaded from the cloud. And that then produced the WhatsApp messages that I gave to the inquiry.
So that's the reason why some of the messages appear there, but not those you exchanged with Professor Smith or Professor Leach. What about the messages you exchanged with the former First Minister, Nicola Sturgeon?
So those would be a very small number of text messages. Ms Sturgeon and I were in each other's company every day. and so most of the business we conducted between us was conducted verbally or by telephone call on occasion. And those text messages, I couldn't find a way to recover those, but I do know that they would be very short, and they were usually operational in as much as me confirming to her that something she had asked to be done, I had done it, or something that she was concerned about had now been fixed or resolved.
I see. So you also told us that in your statement that a WhatsApp group existed for the Cabinet Secretaries for Health of the 4 nations. All 4 health ministers agreed to the formulation of this group. The WhatsApp group was used to facilitate the running of the weekly meetings over Zoom. You provided us with those messages, which you still held. You say, I'm providing the messages I still hold with these individuals to the inquiry. And you did provide us with those messages, yes? And you also provided us with group chats called Health Team and COVID-19 Health, involving junior health ministers, officials and special advisors.
Yes.
Thank you. You, as I say, provided us with a lengthy list of people with whom you corresponded by various different means, including text and WhatsApp. And the position, as I understand it, as you've already told us, is that, that you exchanged a few messages with Nicola Sturgeon by text, is that right? And the main means of communication between you and her, because you were, I think, in the same building as her during the course of the pandemic, was, I think you said, phone calls and verbal exchanges.
Yeah, excuse me, it was primarily verbal, meeting one-to-one or with others, and occasional phone calls and very occasional text messages.
We'll just get back to that in a moment, but the inquiry has also been provided through the Scottish Government with WhatsApp conversations between yourself and Hamza Youssef, yourself and Kate Forbes, and text messages between yourself and Richard Foggo. The reason I mention those is because those aren't mentioned in your statement. Do we take it then, we don't know the answer to this, we take it then that they must have emanated from another source rather than yourself?
Yes, I searched all of those. I searched every single Cabinet Secretary on my phone to double check, and given the time lapse I couldn't be certain of everyone that I might have exchanged messages with. I didn't find any on my phone for either Ms Forbes or Mr Youssef or Mr Foggo, but they came, as you've said, from other sources, and I have seen those.
Yes, and do you then have any explanation as to why those ones appeared not to be in your possession, but a number of other conversations were?
No, I don't. I did not delete messages, primarily because it never occurred to me to do so.
Were you aware of any Scottish Government policy which suggested that you should delete messages, whether sent by way of text or WhatsApp or any similar platform?
I wasn't aware of that policy. That's not to say that I hadn't been given that policy, but in the pace of the pandemic, there were some documents like that I may not have paid as much attention to as I did rightly to others. So I wasn't aware of that policy, and I did not delete WhatsApp messages.
But in any event, you didn't delete text or WhatsApp messages,
No.
and you've explained the reason why, the technological reasons why you've not been able to produce some of the exchanges that you recognise you had.
As best I can, I have to be completely frank with you, my lady, Mr Dawson. I am not the most technologically gifted member of the Scottish Government at that time, and so I searched as best I could and as best as I understood it, and then provided to yourself and to the inquiry everything that I found.
You say in your witness statement at paragraph 17, page 6, all of the noted informal communications, which are the ones listed there, covered variously progress of the pandemic, progress on pandemic response delivery, information exchange, factual and clinical or scientific information, clarification on clinical and or scientific advice received, or problem/issue resolution. All depend on with whom I had the exchange. No decisions were made in any of these informal communications, which were not then entered into the Scottish Government system, the process necessary to record and instruct action. Do you accept that these exchanges are likely, therefore, to hold and to have held important information about the way in which decisions were reached, in particular the scientific basis upon which decisions were arrived at?
Do you mean the messages?
Yes.
No, I don't think that's entirely fair. They were primarily operational. The inquiry has seen, for example, a very long set of text messages exchanged between myself and John Conahan, who was the Principal Operating Officer for the NHS at that point, which are all about operational matters, about whether or not ventilators have arrived or hospital beds or whatever it might be. We weren't reaching decisions in those exchanges because there would be no point in reaching decisions in those exchanges unless you then entered them into the system, because only by entering them into the system could you ensure that they were acted on. Now, I had an agreement with my private office that if, for example, I had a phone call from Mr McCaskill or one of the health union leaders, that I would then tell the private office what the outcome of that call was so that they could keep that record.
When you say the outcome of the call, do you mean any decision that had been reached?
Anything that I wanted to then happen. Usually those calls were either confirmatory of decisions that already had been reached, or the individuals in those examples I've given you were raising with me concerns that they might have around, for example, the distribution of PPE. The systems were in place, but care home X or hospital section Y hadn't received their supply. And so then I would tell my private office and ask for officials to investigate that and sort it out.
But were you under the impression that the obligation to record information on the corporate record was limited to information which showed that a decision had been taken?
No, I don't think the obligation to record on the corporate record was only decisions. And the corporate record from meetings, for example, or from cabinet meetings, and I know the inquiry has the minutes of all the relevant Scottish cabinet meetings, would always have a bit of text, or often have a bit of text that said, in discussion, the following points were made, and then the decision or the action. Mm-hmm. So that was often the case. Because
in the passage that I've just taken you to, information exchanged about the progress of the pandemic, the progress on pandemic response, delivery, information exchange, factual and clinical or scientific information, clarification on clinical and or scientific advice received, or problem issue resolution. All of these things, including, as you mentioned earlier, things about PP procurement and that and the like, all of those things are important context, are they not, to the environment and background against which decisions would ultimately be taken?
They were all important because they were about the matters that I've set out, but you will also, I'm sure, find the context for decisions recorded in the official record, whether that is in cabinet papers or in email exchanges or whatever it might be, because that was the only way to make things happen. You had to put it into the system in order to ensure that action would then be taken.
But your position, as I understand your evidence, is that the obligation, as you understood it, was not limited to recording exchanges which showed decisions being taken. It was wider than that, isn't that right?
Yeah.
And that the width of the obligation included the obligation to record the context, as you've put it?
Yes, well, for example, if I had, and I did have frequent phone calls, usually on my way home at night, perhaps with a health trade union leader or with Mr McCaskill. The context for that, the subsequent email that would go from my private office to the relevant officials would be to set out the context. I'm not quoting exactly here, you understand, but for example, Ms Freeman spoke to whoever last night on her way home. They're raising concerns about, can you do the following?
So the corporate...
the context would be recorded as well as just please do.
Just to be clear, thank you for the explanation, that the context, as you say, which would ultimately be recorded on the formal record by an email or some other means, would include the sort of information that you're identifying there as having been communicated informally.
Yes.
But it would then be recorded formally, if you like.
Yes.
Thank you.
Yes.
You mentioned already that, and you say it in your statement at paragraph 21, that where pertinent issues arose as a result of any of these informal communications that required action by me, these will be retained in the Scottish Government corporate record by my private office. Could you just, I think you've touched on this, but explain the process by which you or your private office transcribed or transferred pertinent issues which arose in your WhatsApps or text into the corporate record?
So one of the examples I've already given, and it did come up in some of those calls or conversations, informal conversations, would be around the distribution of PPE. As you know, and we may come to this, we set up a number of additional distribution routes from pre-COVID times. They did not always work as effectively or slickly as we might want. There was a helpline to record issues, but also specific problems might be raised directly with me, and I encourage that. So I would then say to my private office, I have just spoken to, for example, Donald McCaskill, and he's telling me that Care Home X hasn't received what they asked for. Can you get on to NSS or whichever official it might be and ask them to double check this, find out what's going on and fix it? And they would then put that into an email and give that context. Ms. Freeman has just spoken to Ant.
I see.
And then the reply would come back.
So you've given a helpful example of a maybe hypothetical or unhypothetical situation where you're discussing important matters relating to pandemic management. You've mentioned that you were often, in the period when you were Cabinet Secretary, physically present in the same place as other important decision makers, including the First Minister. Is that correct?
Yes.
Just to expand on that a little bit, just to explain the physical situation, a number of people, and including ministers over that time, will have been working remotely. Isn't that right?
Yes.
But a number of people tended to be based in a centralised office building of the Scottish Government. Is that right?
Yes, that's correct.
And that would include yourself.
Yes.
And the First Minister.
Yes.
And what other key advisors or decision makers, without naming them, just broadly the types of people that would have been involved?
So the First Minister and I would be in St Andrew's House 7 days a week, in fact. We would also have our private offices with us. But in addition, you would have the CMO, National Clinical Director, Chief Nursing Officer, some senior officials. Now that cast list, if you like, would vary, and they wouldn't necessarily be there every one of those 7 days, but they would be there certainly most days, because the practice was that the First Minister and I would have a meeting at around about 11 o'clock every morning, where we were looking at the data that had come in overnight from Public Health Scotland on case numbers, occupancy rates in hospitals, whatever the issues were. We would then, as you know, regular media briefings were instituted. We would then have a very brief discussion just before those, and then a follow-on discussion afterwards, and may then subsequently meet again later in the day, depending on what issues we were dealing with.
So you would have meetings and conversations with, amongst others, no doubt, the key people that you've just mentioned in that list, who may have not been there all the time, but will have been there part of the time. Is that fair?
Yes.
So what mechanisms existed for transcribing into the corporate record verbal conversations, or I think you mentioned also telephone conversations, the type of information that we're both think required to be incorporated into the record, discussions around decision making?
So from that, for example, from that usually 11 o'clock in the morning meeting, there would be often further requests for more information that the First Minister or I or both of us thought we needed, our specific things checked, for example, so that we were absolutely sure of what we were doing and the data that we were basing our actions on. That would then be communicated into the system from primarily the First Minister's private office, not necessarily mine, but the First Minister's private office. And if we had a senior official, or it might be the Chief Medical Officer's Directorate and their office, if we had a senior policy official, then they were tasked with finding something out, taking some kind of action, then they would then put that into the system to their team to do whatever was necessary.
I think what you're talking about there is information that would be obtained externally from whatever the appropriate body was to try to augment your knowledge, data or other such information. What I'm interested in is the extent to which there was a system which aimed to record on the corporate record the nature of discussions taken between or amongst the key individuals whom you have described as being involved in the pandemic response at that stage, about your views on things, the way in which the pandemic seemed to be going, decisions you might take or might not take, why it is that you think one course would be better than the other. If these happened predominantly verbally or on telephones, there was a risk, I think, that they may not have been properly transcribed into the corporate record.
So they rarely, if at all, happened between me and the First Minister by telephone. In fact, I can't recall any discussion quite as you've described it. They would be in-person discussions, and they would be transcribed into the system as part of the context for the ask that was now being made. So, for instance, the First Minister and the Cabinet Secretary are unclear as to whatever this data is actually telling us. Can you please provide more information in order to help them? Help their consideration or whatever it might be.
So the instruction to the external body for more data information would be recorded, but...
The context for it would also be recorded.
Right. In what form?
In the form I've just described. In the form of... So, this is important for everyone we were asking things of. They were working extremely hard, whether they were civil servants, public health officials in PHS, whatever they might be doing. They were very, very busy. So you can't just issue an instruction for X without explaining to them why you want it. And that also gives them a feel for, well, they want this. That must mean that we've not been clear enough so far, so let's give them a bit more information to explain what it is we're telling them.
So we should be able to find that context on the corporate record?
I would expect so, yes.
Thank you. I'd like to ask you some questions about the very early period when the threat of the virus started to emerge. You were the Cabinet Secretary for Health and Sport at that time.
Yes.
You were holding a very important position in a moment of crisis that was coming over the horizon. Is that correct?
That's correct.
And at that time, we understand from other evidence that you were involved in a number of early meetings of COBRA.
Yes.
And also, as we'll come to, a number of meetings of the Scottish Cabinet and similar emergency meetings, including SCORE, the resilience room within the Scottish Government.
Yes.
And over that period, you received a considerable amount of emerging information from other sources. And our understanding is that, broadly speaking, insofar as one required medical advice, that medical advice was coming to you through Dr. Calderwood, the Chief Medical Officer.
Yes.
Could I ask you, please, to have a look at INQ 000 352450? This is an exchange we've looked at before, but I'd be interested in your perspective on this. If we go down to the final page, please, page 5. I think this may be it, in fact. This is an exchange of emails that the inquiry has seen already between Dr. Calderwood and a consultant epidemiologist at Edinburgh University called Professor Mark Woolhouse, who no doubt you will know from his involvement in many different spheres, but in particular the Scottish COVID advisory group subsequently. In this correspondence, as we've already gone through in some detail with Professor Woolhouse, what he is trying to do, it would appear, is bring to Dr. Calderwood's attention concerns, an obvious concern, as you see expressed there, about the developments as are coming to his attention about the threat. And he says the obvious concern, increased by yesterday's not unexpected announcement of human-to-human transmission, is that this will become a pandemic and therefore will affect Scotland. This is not yet certain, but in my judgment it is likely, certainly sufficiently likely, that we should be prepared for the eventuality. Other colleagues share this view. There are some instructive parallels with the H1N1 pandemic in 2009 to 10. Indeed, one possibility is that this could turn out to be quite similar in some key respects, a widespread epidemic fuelled by mild cases, but with mortality among vulnerable patients. As you will, I hope, be aware, there is a series of correspondence in this vein that then comes over the next few days, some of which we might look at. Were you aware of this correspondence having taken place?
I don't believe I was aware of the specific correspondence and in terms of having sight of that email or the correspondence, but I did know from Dr. Calderwood that Professor Woolhouse had been in touch with her, as had others, or she had also reached out to others, experts in this field that she was aware of, and clearly her colleague CMOs in the Four Nations.
And when did you become aware of these exchanges? This is the 21st of January 2020.
I can't recall the specific dates, but I would think around about the same time as these exchanges. I mean, we were conscious that this, I can't think of another way of putting it, this thing that appeared to be emerging from China and appearing elsewhere was potentially very, very serious indeed. And of course, his reference to the H1N1 pandemic resonated with the former First Minister, Ms Sturgeon, because she had been Health Secretary during that time. Mm-hmm.
What was the significance of the H1N1 pandemic in the assessment of the level of the threat?
So people were, I clearly was not in government and wasn't an MSP at that time, people were referring back to that and referring to the concern that they had around the seriousness of it at the point, which did not then play out in practice, but were also very clear that that may have been the case then, but we don't know that this one's going to be the same. And of course, as you know, and I'm sure we will come to, subsequent modelling of the Covid-19 virus produced some very stark numbers about its likely level of impact on the population.
We'll get to that in a moment, yes. Is it fair to say, therefore, that the H1N1 experience provided a degree of reassurance in the approach, given that it has not turned out in Scotland to be as serious as it might have been?
I did not find it reassuring. I found it interesting to understand what had happened then, but my primary position was that was then, this is now, and we don't know it's going to be the same.
What was your understanding of, at this time, of the significance of the possibility raised by Professor Woolhouse that the epidemic may be fuelled by mild cases? At
that point, I don't think, as a non-clinician and not a scientist, I don't think I had a particular view. I think it's one of those situations where you hear that, you say, well, it might be, but the other voice in your head is saying, but it might not. Let's find out. Let's keep finding out till we know.
Obviously, it is correct to point out, Ms Freeman, that you are not a clinician, but of course you were in a position to receive medical, clinical and scientific advice from, amongst others, the Chief Medical Officer. Was she explaining to you at this time the potential significance of an epidemic fuelled by mild cases?
No, not in as categoric terms as those. She was explaining what she knew had happened when it was H1N1, but also keeping very much open the door in our minds and in her own that this may not be the same kind of epidemic, and in fact became a pandemic.
Professor Woolhouse also mentioned the possibility of mortality among vulnerable patients. Yes. What did you consider, or did you understand from Dr. Calderwood or otherwise, this class of vulnerable patients to constitute? Who were these people that he was talking about?
Those would be, I understood it to be, and in my own mind would think it to be, people who had other serious clinical conditions, comorbidities, and that would also include those who were elderly, but not exclusively those who were elderly.
Thank you. If we could scroll up, please, to the 25th of January email. Page 4, I think, wasn't it? Maybe 3. So this is a further piece of correspondence, again from Professor Woolhouse to the Chief Medical Officer, Dr. Calderwood. In this, he reports some further information relevant to the epidemiology, including the basic reproduction number, of which there was a central estimate of 2, the R0, and the case fatality rate of 4%. Again, were these things that were brought to your attention at that time, and was the significance of these figures explained to you?
Yes, they were, and in those numbers around the R number, as I think we all came to clearly understand it and talk about it, the ranges were there. Of course, Dr. Calderwood was receiving information not only from Professor Woolhouse but from others, and all our science, epidemiologists, virologists, colleagues and chief medical officers were working hard to try and get a grasp of what we might be dealing with. So we were often dealing with a range of information. It could be between this and this, for example. In any event, as I heard it as, this is very serious.
Mm-hmm. You say that advice was being received from others at this time. Could you recall who were the other advisors that were providing input, similar on the same subjects, at least, as Professor Woolhouse?
So Dr. Calder would be attending discussions with the other CMOs and, of course, the chief scientist, including discussion with the chief scientist for health. And there would be others that she was in touch with as a consequence of her career. I don't have the names of those, but she would mention them, who she had been speaking to, and the calls that she had been involved in, and what she was understanding from all of that information that she was gathering in.
The message which we've seen on a couple of occasions in the sort of middle paragraph here in the bottom half of the page relates to putting the numbers that I've just mentioned into an epidemiological model for Scotland, and that the prediction would mean over about a year at least, oops, we've lost that, half the population will become infected, the gross mortality rate will triple more at the epidemic peak, and the health system will become completely overwhelmed. We can formalise those predictions, and there are many caveats to them, but these are the ballpark numbers based on information from the WHO. Please note that this is not a worst-case scenario. Yep. This is based on WHO's central estimates and currently available evidence. The worst-case scenario is considerably worse. I'm not sure, Ms. Freeman, one requires to be a clinician to read that passage with a considerable amount of trepidation about the position.
No, you do not. And I think, as I've already said, I had a growing feeling of trepidation about what we were about to have to deal with all through that month of January. And that feeling on my part was not in any respect undermined by Dr. Calderwood, who herself was increasingly clear with me and with her colleagues in the Health Directorate about just how serious this could end up being, and to quickly disabuse ourselves of any notion that this might be a repeat of H1N1.
What steps practical steps were you advised that Scotland should start to take in order to deal with this threat?
So the numbers that are indicated here and the numbers that then fed into the 4 Nation action plan that was published, I think, at the very beginning of March.
3rd of March, perhaps.
Those numbers were emerging. They weren't finalised, but they were emerging. And what that told me was that a significant proportion of the population, a very high proportion of the population, would be infected, that a significant proportion of that number would require hospital treatment, including intensive care treatment, and that a proportion of that number would also die. And so that told me that I had to begin work or undertake work with our health service colleagues, our NHS colleagues, to look at what is our current bed capacity, what do we need to do to increase that bed capacity so that we can take people who are ill, what is our current position in terms of ventilators and ICU, and what do we need to do to increase that. In both those figures, the obvious answer, the clear answer was we need to increase bed capacity and we need to increase ICU capacity. And so work began to look at how do we do that.
Just to be clear as best you can, with a bit more precision, to be fair to you, about the timeline. When was it that you mentioned ventilators, ICU capacity as being a primary consideration in light of this information? But when did it start to be that was your focus and you started to take steps to try and investigate what the capacity was and what you might do about it? Was it at this time in January or was it later?
January into February.
Right.
I think we had, I'm not sure if I have it with me, but we had an early number in February, an estimate of the size of the population in Scotland that would be infected by this virus. And of course, then there was, as I said, the modelling in the four-nation plan.
Was the modelling that was done around that time simply taking the UK figures and scaling them down for the relative size of the Scottish population, or was it based on specific Scottish information?
So at that point, in the early days, it would be looking at how the UK-wide figures would be apportioned in Scotland, but then work was undertaken to factor in other factors, for example, the levels of comorbidity amongst our population, the level of health inequality amongst our population and so on, to refine the figures. But the bottom line is the figures are high.
Yes.
And you can model them to make appropriate changes. That doesn't alter the fact the figures are high. And as you know, the 3rd of March modelling, the reasonable worst case scenario was 80% infected, 4% requiring ICU, 4% of that 80%, 1% deaths. Those are big numbers, and the February modelling number that I received was 75,950 hospital admissions in Scotland. Right. Now, they're not all admissions at the one time, of course, but over the piece, that's what was expected, and we had a bed capacity of 3,000.
Right. You mentioned that there was a point at which what one might describe as local data was taken into consideration and one wasn't deriving it simply from the UK data scaled down. I think you recognised that it was important to do that based on the demographics of Scotland's population, in particular its elderly population and the existence of a number of comorbidities and health inequalities. Did I pick you up correctly?
Yes.
When was it that that local data started to be factored into the planning?
So the analysts would begin doing that through February. I mean, hence we had a number given to us in February as a modelling number. And the analysts were quite clear, quite rightly, that modelling was not a prediction, it was a model, but it gives you an idea of what you might be dealing with. And they would then begin to factor in some of those other factors to see what changes that might make. But from my point of view, I didn't see that modelled number of just under 76,000 coming down because Scotland has a higher comorbidity, a more elderly population, greater health equalities. I could only see it rising.
Yes.
So let's just deal with this. It doesn't matter if you add 10,000 onto this or whatever you do, this is a big number and we need to do serious work to try and deal with this.
You're focusing, quite rightly, on the question of ICU capacity, ventilators, hospital capacity. But of course, there were other more specific measures that might be taken into consideration in order to try to deal with the particularly vulnerable individuals whom we've identified. What steps were taken to try to understand the extent of Scotland's vulnerable population in order to try to inform the best measures that might be taken to try and protect them?
So that understanding, if you like, or that work comes into play when you start to look at the specific measures that you might take. So whether you're looking at the impact of the virus on a particular part of, for example, Glasgow, where we know the health inequalities are higher than another part of Glasgow, it doesn't really matter too much in terms of hospital admissions and ICU demand. You know what you're going to get. Where it does matter is when you're looking at vaccine take-up, access to testing, and so on, further down the line. And also your communication, so that what you're trying to ask the public to do is communicated as widely as possible in order to reach all areas of the population.
Just to be clear again, and to try, if we can, to put this in the timeline. When you mentioned there, for example, obviously access to vaccines came much later, although very much under your watch, if you like. As far as access to testing is concerned, you mentioned, I think, that was something that was being considered for more vulnerable people further down the line. When did access to testing for more vulnerable people become part of the narrative?
So, to be clear, so we don't misunderstand each other, access to testing was significant in my mind from the outset, not least because we did not have sufficient testing capacity and capability. So my initial concern was not who is going to be able to be tested, but initially, how can we increase our testing capacity? That was the first and most important thing to focus on. We started out with a per-day testing capacity of around 350 tests. The very initial, the very, very early tests for COVID were sent, I believe, to Colindale. And I think you have heard from other witnesses as well that the tests were being developed for this particular virus, as they have to be for all particular viruses. But particularly in answer to your question, my primary concern initially around testing was our capacity and capability to process tests speedily and in a higher volume than the 350 that we started out with in February.
So was that the capacity for testing throughout February, was 350 a day? Yes. Is that right? And how long did that last for, do you recall?
So that was our starting point. By the 18th of March, we had 780 capacity per day of PCR tests across 3 of our NHS labs. We increased that by the end of April to 4,350. And of course, by that point, the Glasgow Lighthouse Lab, part of the UK Lighthouse Network, was being established. And as the NHS laboratory testing increased, the Lighthouse laboratory testing also came in, not exclusively for Scotland, for tests, to process tests taken in Scotland, but a significant proportion, but it was part of the UK network. So the capacity increased exponentially from that point, but in those early days and months, the capacity was low.
Did you ask anyone why you had such limited capacity at the beginning?
I did, and my lady and I probably asked them in fairly robust terms. And I think, in fairness, I can't recall the specific answer, but I think in fairness, the answer would be that in the prioritisation of NHS resource over the years previously, it had not necessarily featured highly, and the resource, limited resource for our health service had been prioritised elsewhere.
So one of your predecessors?
It could have been many of my predecessors from the point when the Scottish Parliament reconvened in 2000. I think it is one of the significant lessons, if I may, and my apologies if I'm jumping ahead, but one of the significant lessons is the importance of retaining a core testing capacity that you can scale up. Now, that's not straightforward. It's about the skills, it's about the kit, as well as, so it's about the capability as well as the actual capacity. And so it is disappointing to me that the Glasgow Lighthouse Lab wasn't retained because I believe it was a UK government decision, but I believe it could have been repurposed for other important tests in Scotland. Now, regional laboratories were built up, NHS regional laboratories were built up, and part of the thinking behind that was to retain a core capacity post-pandemic. But Mr Dawson, you're rightly pointing me to where we were at the outset, and that is where we were.
Thank you. Is it the case, therefore, because you've highlighted that there are a number of component parts one has to have to an effective testing system, is it the case that at this stage Scotland did not have the skills, the kit or the capability to carry out adequate testing?
Well, I would say Scotland certainly did have the skills, and the Glasgow Lighthouse is testimony to that in how it could bring skilled personnel in so quickly. What we did not have was the physical space or the kit in order to do that. And so we began the increase in our existing NHS laboratories with that increase to 780. That was in the NHS labs in Glasgow, Edinburgh and Dundee. And then by the end of April, every one of our territorial boards had local access to that testing, processing of tests. It's actually, strictly speaking, what it is.
If we could go back, sorry, it's my fault for not asking to keep it up. The INQ 000352450 again. This is the Professor Woolhouse emails again. I'm looking now at page 2, please. There are various scenarios. This again is another one in the chain of correspondence from Professor Woolhouse, where he sets out various scenarios. He talks about a third, a SARS scenario. And talks about various things that might be done. He says there, this is the scenario that I learned for you yesterday, though I didn't give you the worst case version of it. This is what we have to expect if the current case fatality rates are roughly correct. The measures we would consider are, first of all, a vaccine, and then going over the page, various other antivirals, and then effectively he rules that out as being something that's open at the moment. And so he says back to public health measures. And he points out there that public health measures which ought to be used are case isolation, infection control and contact tracing, public messaging and social distancing. So these are, you've talked about the testing capacity being built up subsequent to this, but at this stage, what is being suggested is that there needs to be case isolation, which means that it requires to be testing before one can find out what the cases are. Isn't that right?
That's right.
And that there also needs to be a system put in place of infection control involving contact tracing, so finding people that might have been infected by the index case. Is that correct?
Yes.
As far as we've talked about the testing capacity, but as far as contact tracing systems were concerned, our understanding is that that wasn't put in place until much later, when the Test and Protect system started. Is that correct?
No, not quite. It was certainly scaled up at that point, but Scotland has always had, through our public health system, a capacity for contact tracing. It's used through our local incident management teams, who may be at this very moment be undergoing contact tracing, perhaps for sexually transmitted disease in a particular area, or for other viruses that arise. So we had that system in place that undertook contact tracing, and it was that system that we used to build So contact tracing, as I know you know, was used for the cases that came from the Nike conference. That was the use of a system already in place.
What efforts were made at this time to try to expand that existing contact tracing system or build a new contact tracing system to the level and scale of the sorts of prognosis or prediction that Professor Woolhouse was making?
So in the first phase of the Four-Nation Plan, it is about containment, and that rests a lot on contact tracing. Of course, contact tracing begins with a positive test. And so where you have limited test capacity, your contact tracing is, from the outset, limited. So the scale up, limited though we might see it as being at this point with hindsight, was part also of being able to have more contact tracing if that was what was needed.
Why is it necessary to look at the deficiencies in the scale-up of the contact tracing system in hindsight? Because what you had here was a recommendation from a recognised epidemiological expert as to the kind of scale that you might be looking at and the need for contact tracing to try to prevent that. At the time, it was known that that would be necessary, isn't that right?
Yes, so with respect, that what you said I said is not what I said, if I may. Mm-hmm. What I said was that in order to scale up contact tracing, you have to scale up testing. Mm-hmm. And, you know, as we look at it now, going from 350 in February to 780 by the 18th of March may not look like a significant increase. Mm-hmm. And it wasn't a significant increase, but it was the best that we could do in that, at that point with the resources that we had. We then increased that, as I say, significantly by the time we got to April, but that is about acquiring premises, kit and people. But that's fundamental to a number of things in responding to the pandemic, but it is fundamental to contact tracing.
To be clear, when you talk about a lack of resources, you're talking about a lack of premises, kit and people, is that
yes.
right? So that's what you had to build because it wasn't there before?
Yes.
As far as public messaging is concerned, Professor Woolhouse was also of the view that this was tremendously important. Yeah. You've mentioned the Nike conference and the public messaging around that. What public messaging about the threats took place in February?
To be honest, Mr. Dawson, I can't recall. Certainly, I know that I had alerted Cabinet colleagues to the virus through our scan system, which I think you're familiar with. It's basically a notification system for every Cabinet meeting to every Cabinet Secretary on issues of importance that you think your colleagues need to know about, but no decisions need to be taken at this point. So the first scans that raises COVID-19 is the 28th of January. So I was certainly alerting Cabinet colleagues at that point to this matter, but I can't recall at that point if there was specific public messaging.
Cabinet colleagues were, of course, members of the public, but telling Cabinet colleagues is absolutely not public messaging, is it?
No, no.
So, I mean, you know that we've heard evidence around the way in which the outbreak at the Nike conference was handled in terms of public messaging. But in effect, there was no public messaging of the threat until the first case was announced on the 1st of March. Isn't that right?
I believe that is correct. There was a lot of work going on to reach Four-Nation agreement around the first Four-Nation plan, and a lot of agreement around our work going on to reach collective agreement where we could about the information that we would base our plan on, but also the information that would be used to communicate with the public.
It was subsequently, as I understand it, an important principle of the Scottish Government's public communication policy that there be honesty and truthfulness about what was going on with the people. Is that fair?
That's correct.
Why was there not a similar approach to alerting people to the threat, in particular in light of the fact that Professor Woolhouse had already alerted you to the fact that it was tremendously important?
Well, to be fair, Professor Woolhouse had alerted Dr Calderwood to that fact. We were
you not aware of that?
As I said earlier, I don't recall seeing his correspondence as such. I do recall Dr Calderwood telling me about hearing from Professor Woolhouse and broadly what he was saying, along with others that she was also hearing from. And I think we know that the scientific community and the academic community was engaged in constant discussion where there was not always agreement, understandably so. I mean, science is an iterative process. So we understood the emerging seriousness of the problem, as I think I've already indicated, but you have to be clear of your ground before you communicate that more widely. It's not overly helpful to people to say, we think there might be a problem, but we can't really tell you at this point exactly the size of it.
Is it your position that you were aware that recommendations were being made, a recommendation had been made by Professor Woolhouse or others, that public messaging was tremendously important towards the end of January?
I don't recall specifically being made aware of that, but I am personally very aware of public messaging being important.
Could I then look, please, at another document, which is INQ 000238707. This is, I think, as we've clarified with other witnesses, this is effectively a cabinet minute, which tend to be called in Scottish Government conclusions, as we've picked up from other similar documents. This is minutes, effectively, of the Scottish Cabinet meeting on the 28th of January 2020. Could I look at page 5, please? If we actually, look at page 4 first. As far as coronavirus outbreak is concerned, you presented a paper about this at this particular cabinet meeting, is that right?
No, this is the scans note.
Yes, but you're speaking to the cabinet meeting, yes, about that. And on page 5, please, paragraph 17, over the page. In discussion, the following points were made. The rate at which the virus was spreading in China was alarming, as was the suggestion from Chinese officials that the virus might be infectious in its incubation period before symptoms began to show. If confirmed, this would make controlling the virus much more challenging. It would be important for Scottish Government messaging to be consistent with the latest evidence concerning how the virus spread. What was your understanding at that stage of the significance, first of all, of human-to-human transmission, which we had seen in the previous correspondence from Professor Woolhouse, and this apparent development that there may be transmission in the incubation period before symptoms began to show, as regards the difficulties that one might experience in any response?
Yeah, so that was emerging information. I mean, we had, I think, on the 24th of January, pretty categoric advice from policy officials, but based on, 24th of January, clear advice with respect to the scientific knowledge at that time that people carrying the virus are only infectious to others when experiencing symptoms. So that was pretty categoric advice that there was no asymptomatic transmission. That, of course, began to change as various experts in the field understood the virus better.
You used the expression a moment ago that science is an iterative process, and no doubt that's the case. Is it not very important in moments like this to understand that if one waits to see a hard scientific conclusion, that it's likely to be too late to do anything about it?
It is important to not wait unnecessarily for a hard scientific conclusion, as you put it. And I think as the pandemic progressed, we increasingly understood the importance of acting fast. But at this time, it still felt like there was a degree of uncertainty around about exactly the nature of this virus in terms of how it would behave. And therefore, what did we need to do?
So the conclusions about what one should do at this stage were based on what you felt. Is that right?
But also, no, not entirely. I don't think that is fair. We also had the benefit of the CMO's advice from her discussions with her colleagues in the rest of the UK and with Professor Van Tam, of course, as the chief scientist and others. So we had the benefit of her advice that this was an emerging serious situation.
Just to be clear, I think the advisory systems of which we're aware at this stage were predominantly chief medical officer. So it would have been Dr. Colwell dealing with Professor Whitty.
Yes.
And you mentioned the chief scientific officer. That at the time would have been Sir Patrick Vallis,
Yes,
who I think was also heavily
Yes.
engaged at this time. So those would be.
Yes.
Is that, am I right in thinking?
Yes, you are.
Professor Van Tam,
Yes, you are. My apologies.
It said at paragraph B, it was likely that in time the virus would reach the UK. The Scottish Government was putting in place appropriate measures in all parts of the country to minimise the risk of contracting the virus and to control the spread of any outbreak. Which of the measures that Professor Woolhouse mentioned in his prior email that would achieve those aims were the Scottish Government putting in place? What were these appropriate measures?
So we were beginning at that point to look in some detail at what we might need to do in terms of our NHS in order to increase capacity in the health service, as well as increasing kit like ventilators. We were looking at what this might mean for our PPE procurement, and we were also actively looking at our testing capacity and what we needed to do to increase that.
Subject to the limitations that we explained a moment ago.
Yes, but also how could we get around those limitations? What was available in Scotland by way of private sector testing, and there were one or two facilities, as I recall, perhaps more, like that in Scotland, of limited capacity, but nonetheless they existed, and whether or not we could contract with them to provide their service to the NHS.
I want to ask you about that, actually, the private sector. Did it turn out that there were any private sector facilities for undertaking testing or any of the other processes required within the private sector?
So from my memory, there was at least one, possibly two private testing facilities. I think one subsequently was also used by St Andrews University, but I may be wrong about that.
But
we also reached
over this period in particular?
Yeah, over this period, I think there were one or two. We also were, of course, looking at private health facilities in terms of bed space, not for COVID, but for other procedures, right, and whether or not we could, if you like, buy up those beds for the NHS. Because,
as I think you've candidly accepted, there were issues with the NHS's capacity to undertake testing and ultimately tracing,
yes,
which existed at that time.
Yes.
It might be suggested that greater efforts should have been made in light of the apparent urgency and severity of the threat to access testing and tracing capacity in the private sector.
My understanding is that what the private sector could provide was testing. Contact tracing is a skilled exercise that was undertaken by our public health colleagues. And as I've already said, we already had a network, a local network through our local incident management teams, public health incident management teams that worked on contact tracing continuously where there was a requirement for that. And so we wanted to use that expertise to expand the contact tracing capacity. Mm-hmm. But to do that, you need to expand testing.
And did these forays into the private sector in this period result in any further testing being done beyond the capacity that you've already mentioned?
From memory, we did use at least one lab, but whether or not we used, I don't believe we used it in this time period, which is January, but we
Well,
brought
I
it
was
in.
talking about the period that you were talking about where you gave figures for January, February and March and
Yes.
April. Over that period were private
Yes.
facilities used?
Yes.
And to what extent, therefore, did they boost the numbers that you've told?
Their numbers were very small, but we were not in the business of curvailing at small numbers. We needed all the capacity we could get.
Thank you. Just before we take this away, there's one aspect of this I just wanted to follow up with you. You've mentioned already the collaboration with people like Patrick Vallance and Chris Whitty. This minute records at paragraph E, while there had been good collaborative working between the UK's chief medical officers, the UK government had not been sufficiently responsive to requests from Scottish Government for information, including about UK nationals currently in China, and had not fulfilled a number of the commitments it had made at the Cabinet Office briefing room meeting held on the 24th of January. This point would need to be raised urgently at senior official level. This is something we've seen from other witnesses, that there seemed at this period, and if I recall the evidence going forward, to be issues with access to information which the Scottish Government needed from the UK Government. Can you recall what the details of this were? Can you elaborate on what sort of information was lacking and how that was impeding Scotland's response?
So the particular meeting that's referred to there is the first, I believe, the first COBRA meeting, which was chaired by Mr Hancock, in which I and the Scottish Chief Medical Officer attended. My feeling at that meeting was that there wasn't sufficient urgency from the UK government, and I do recall raising in that meeting or querying their intention to focus on flights into the UK from Wuhan, and suggesting that international travellers often travelled via hub centres like Schiphol or Dubai, and that we should be looking at flights from there too, if we were talking about trying to ensure that we knew whether the virus was coming in via any of those routes, and that not being considered the right thing to do. I believed that was wrong and said so, but of course that was not within my purview as a Scottish Health Secretary. And there were times then and subsequently when Scottish Government officials were frustrated by slow information or the absence of information. To be entirely fair, in my dealings with Mr Hancock, subsequent to that COBRA meeting, where I think we had a bit of a disagreement, but subsequent to that COBRA meeting, I found that if I spoke to him directly on matters, then we could resolve them.
In the period between January and March 2020, did this information flow issue from the UK government constitute an impediment to Scotland's preparation and understanding in connection with the pandemic?
None that I was aware of.
Thank you. If that's an appropriate moment, lady.
Certainly, just before we break, Ms Freeman, looking at B, Mr Dawson asked you about what measures were put in place. The statement in the minutes is that the Scottish Government was putting in place appropriate measures. When you answered his question, I wrote down your words, not literally verbatim, but they're all, we were beginning to look at, we were looking at. Given that you were still at very early stages, was putting in place appropriate measures something of an overstatement?
No, I don't believe it is, because I think that as we looked at things, we agreed things pretty quickly. So looking at, for example, would it be possible to use private laboratories to increase our testing capacity? Usually, under the leadership of Mr Conahan, those phone calls would be made. He would come and tell me, I would agree, go contract them. So looking at and doing were often a matter of a day, hours between one and the other.
Thank you.
Thank you, my lady.
Break now until 3:15, please. Mr Dawson.
Ms Freeman. I'd like to move on just a little bit in the timeline into February. We understand that on the 12th of February 2020, there was a ministerial tabletop exercise called Exercise Nimbus, which took place. The intention of this exercise was to test the decision-making process by COBRA in response to a fictional scenario drawn from the real, reasonable worst-case scenario pandemic influenza plans. Now, we understand that you did not attend this, and one of your junior ministers did.
Yes, that's correct.
Do you have any understanding as to, we have various documents about this, but broadly speaking, do you understand what the significance of this exercise was in pandemic planning for the real pandemic, given that it was a hypothetical exercise, though based in a hypothesis that was actually quite close to reality?
Yeah, so I understood it to be an attempt, if you like, to almost update or double-check planning against the flu pandemic, potential of flu pandemic, which had informed most of government planning prior to Covid-19.
Mm-hmm. Given the circumstances and the severity of the circumstances, in reality, that you've just understood, was you just explained, was your apprehension of the Professor Wheelhouse and other medical information you were privy to. Was it not important that you attend that in order to make sure that Scotland's position was as up-to-date as it possibly could in the planning?
I think it was important that a Scottish minister attended, and that's why Mr Fitzpatrick did. I can't recall, I don't have my diary with me as to what else I was doing at that time, but I would have made a decision that whatever else that was required my personal attention more than this did, and I of course had confidence in my health minister to attend, to ensure that any points that we wanted raised were raised, and to feed back to me on the outcome of that.
The minutes or the note of the meeting record the exploration, I think, of a whole load of different agencies and departments of the UK government that might need to be engaged in a response. So for this part, we need to engage with this part of government. Mm-hmm. There is only one reference that we could find to the Scottish Government, which is, it says, Scottish Government SG outlined that they had activated their response and were thinking about the same issues. There had been good collaboration across CMOs. They emphasised that everyone had to be clear about priorities before decisions were made. Now, to be clear, as I understand it, this is a hypothetical position of the Scottish Government in a hypothetical exercise, although one would have expected, would one not, if the purpose of this exercise was trying to update the planning and apply it more to the potential real-life situation that was evolving, that the Scottish Government would have had more to contribute and say than simply that.
I'm not sure if that would be fair. It wasn't the Scottish Government responding hypothetically. It was the Scottish Government saying that, for example, our resilience room had been set up, and one of the purposes of our resilience room is to draw together different relevant parts of government to focus on and coordinate action in response to. So it would do that on flooding, for example, did it when there was the attack on Glasgow Airport, and it was stood up, excuse me, for COVID. So it brings, if you like, it coordinates the different parts of the Scottish Government. So we don't need to go through a big list of different bits of Scottish Government that need to do things. This resilience room does that.
But if this exercise, the UK government seemed to list all the various different things it was going to do, if Scotland was going to play an active part in that, would it not need to be absolutely clear in the updated plan exactly what it was that the Scottish Government was going to be relied upon to do? Well,
it would be clear in the updated Scottish Government plan. And whatever came from that Nimbus, exercise Nimbus, would feed back into that, and that would include giving me feedback from the exercise itself. So I knew what the UK government was planning and would be able to check that we were paralleling that, if you like, as well as anything else that we might be doing.
Was it anticipated at this stage that if matters did escalate either along the lines of Professor Wheelhouse's predictions or something similar to that Scotland's role would be to allow the UK government to decide upon policy and for it to implement an operational response within Scotland?
No, that wasn't the understanding on the 12th of January. The understanding at that point, in my mind, would be that we would see four nations collaboration in response to a virus. And what that means is that as far as possible, we would share information, share decision-making, agree the direction and the response that we would take, coordinate that where that was possible. But as it turned out, each of the four nations caveating that approach by saying, but in addition, we may diverge one from the other, depending on our judgment as to what is right for the population that we serve.
If that was the Scottish Government's position, should it not have set it out as a part of Exercise Nimbus?
Arguably so, but it does not appear from the note that we did.
Thank you. There was a civil servant, I understand, who worked alongside you called Derek Grieve.
Yes.
Is that correct? He was the Deputy Director for Health Protection Division within the Directorate of Population Health. Is that correct?
Yes.
We have looked already at some notes he kept in his notebook over this period, and they are at INQ 000346137. And he attended a number of key meetings around this period with you and was generally engaged in the Scottish response. Is that fair?
Yes.
Page 14, he says, this is the Wednesday, the 26th of February, we understand it, attended Cobra M meeting with CABSEC, that would be you.
Yes.
And it's clear all departments in UK government are fully engaged and mobilised in a way that the SG simply isn't. Then in the next day, it refers to someone trying to encourage them, but with no real engagement. They then spent 20 minutes talking about internal SG comms, completely amazed. And then on page 18, this skips forward a week or so to Thursday, the 5th of March. Where he says that I attended directors' meeting, I think this is the top, laid it out thickly, but few believe this is going to be serious. It appears here that Mr. Grieve is suggesting that within his department, within your department, a directorate, I should say, that there was a general lack of awareness of the severity of the situation, in contradistinction, it would appear, to the position in the UK government.
Well, certainly if that's the case, it is in contradistinction to the position of health ministers, myself included, or the First Minister or the Deputy First Minister for that matter. It's clearly Mr. Grieve's feeling and view, and I'm not going to cavil against that. I think he was reasonably frustrated that other parts of the directorate, it's a very big directorate, appeared to him to be taking a view that this was a public health matter and therefore not for them. That was probably fair in those early days, but of course the directorate had to come together fairly quickly, because in the same way as we had to redeploy NHS staff to respond to COVID, we had to redeploy, not I personally, obviously, the senior civil service had to redeploy civil servants to strengthen parts of the directorate that were responding directly to the pandemic.
And officials required to take forward practical actions based on the threat, such as the testing programme, etc., that we discussed earlier.
Yes.
And these would be the officials that he's talking about who would have required to take those important practical actions forward on your instruction or otherwise.
Well, they would be under the leadership of the Director General at that time, and also of Mr. Conahan. Both of those individuals, I had a great deal of confidence in their ability to corral individuals to take the action, not just take the action that we required them to, but to do so speedily And of course, Mr Conaghan was in daily contact with our NHS boards as well, where a lot of the action had to take place too.
You may recall, I hope you recall, that 2 international rugby matches took place towards the end of February, or were due to take place towards the end of February in Italy. The Scotland's men's international rugby team played in Rome on the 22nd of February. The women's international rugby team had been due to take place, due to have a match on the 23rd of February, also in Italy, which was eventually cancelled due to local concerns about COVID. Was this a matter that was on your radar at the time, in particular in light of concerns about the spreading virus in northern Italy?
Yes, excuse me, yes, it was.
And what advice did you receive about the dangers that might be created by groups of people, not just, of course, the teams and people themselves, but the supporters that would be going to the game, possibly going to Italy and coming back to Scotland subsequently?
Yes, so the advice I received, which came from the CMO, but also was advice through her from Health Protection Scotland, and I believe some of this was at least discussed at SCORE meetings, was that the risk of spread in an outdoor setting was less than that when people were indoors, that people were already coming here, and if we cancelled the actual match, more of them would concentrate or congregate for longer in an indoor setting where the risk was higher.
I wonder whether we might be at slight cross purposes here, Ms Freeman. I wonder whether the response you're giving relates to a later rugby match that was taking place in Scotland. What I'm talking about is in the international season, the matches take place every week or 2 weeks.
Okay.
There was, we'll get onto that in a moment, but what I was asking about was matches that took place towards the end of February, or one took place, one was due to take place, of the Scotland men's and women's team in Italy. So these were away matches. So I wondered whether that was a matter that had been brought to your attention, because of course a number of people would go to those matches, supporters as well as those actually participating, and they would come back to Scotland subsequently. So was that a matter that you received advice about?
Yes, my apologies.
Also.
Yes, I was aware of those matches and of the risk, if you like, of people returning from those matches, but also people returning from skiing holidays, for example, which often took place around about that time.
Mm-hmm. We're aware from the PHS report into the circumstance of the Nike conference that there were somewhere in the region of 300 entry points for COVID, in reality, subsequently found out, that came from continental Europe. And therefore, would it not, at least in hindsight, be something upon which you might have a comment as regards the advisability of sending large groups of people to northern Italy, which was the very area that was associated with outbreaks at that time?
I'm not quite sure what you're asking.
What I'm asking
we should have stopped people going?
Yes.
We could have issued advice to people not to go. We couldn't actually stop people going. And in a similar vein, people returning, we would require that information to come from the UK government so that we could, had we had the capacity, have tested them on their return. So it was not something entirely at the hand of the Scottish Government.
When you say that you could have advised but not could have stopped them, what was your understanding of the powers of the Scottish Government at that time with regard to controlling its borders in that way?
So my understanding at that time was that the Scottish Government, that the UK Government controlled the borders into the UK.
For all purposes? For all purposes?
Yes.
Thank you.
And the Scottish Government's responsibility was for public health measures inside Scotland.
Thank you. There is subsequently a meeting of the Cabinet on the 3rd of March, there's just one aspect of that. We might not have to go to the minutes for this. That there is a record on page 5, this is on the 3rd of March. Again, this is updating again with further information that's becoming apparent, similar to the minute we looked at before. It says there that COVID-19 would also have a differential impact on different groups within society, such as the most vulnerable and older people. Unlike influenza, the new coronavirus appeared not to pose a serious risk to young people, but had a disproportionately serious effect on those in their 70s, 80s and over. Now, that's very helpfully been put up. Just to be clear, does that reflect your understanding of the risk profile, if you like, as the science was showing at that point?
Yes.
That's the 3rd of March.
Yes, it does.
Thank you. Could I also please, in that minute, go to paragraph 15? Just to be clear, it's INQ 000232901. Page 4, thank you. Thank you very much. Just the top paragraph there, Ms Freeman, it says, although containment remained the highest priority, it was likely that the response to the outbreak would move into the delay phase in the near future. The objective during that phase would be to maximise the NHS's ability to cope with the outbreak by spreading the number of cases over a longer period. Ideally, it would be best to delay the spread of the disease into the summer months, when it was thought that the medical effects might be less severe, although this was as yet not proven. Delay would also bring nearer the time when research into the possible vaccine might be closer to bearing fruit. 16. During the delay phase, the authorities' principal tool was likely to be social distancing, which could include restrictions on large-scale gatherings such as sporting fixtures or cultural events, but it would be important not to implement such measures prematurely. And at paragraph 19 on page 4, it says, it appeared likely that over the next few months there would be a relatively slow increase in the number of cases from the current very low base, given the efforts that were being put into containment. At present, there was little evidence of community transmission in the UK, and new cases tended to be in clusters, hence the continued importance of contact tracing as one of the main containment strategies. It was, however, likely that containment would reach its practical limits over coming weeks. So do we take it from this that as at the 3rd of March, the Scottish Government was under the impression, first of all, that it would be important not to implement measures prematurely?
Yes.
Sorry, I was just going to ask what the basis of that understanding was.
So there was continuously all through the response to the pandemic, and as far as the time period that I was involved in it, there was a continuous discussion between judgment, between what I said earlier about act fast, act decisively, but an argument that said if you act too quickly, i.e. prematurely, then you don't have enough evidence and rationale to convince the public that they should comply with what you're asking them to do. Mm-hmm. And so the tension, if you like, is between the urging to act fast and act decisively, and the other argument that comes that says, but people won't know why you're stopping them from doing things, and if they don't believe is a good reason, they're not going to comply with that. And we don't want to get into a situation where we need to be in public health in a situation where people believe there is a basis for what you're asking them to do that is about protecting themselves but also protecting others.
One of the reflections that Professor Smith, when he gave evidence to the inquiry, shared with us was that he was under the impression that one of the things one might do better in the future, if you like, was that greater reliance could be placed on behavioural science in order to try to assist, I think, with the balance that you're trying to point out. Was the position that it would be important not to implement such measures prematurely based on any scientific advice?
I believe so. I believe it was discussions that had been held in SAGE, but also, I believe, between the 4 chief medical officers. It was certainly part of the discussions that I had with the CMO and with the First Minister. And of course, as you know from a previous witness, we did reach out to gain expertise in terms of behavioural science as we progressed.
We've heard from Professor Reicher, who is a member of SPI-B, but also served on the Scottish COVID advisory group. That, of course, wasn't constituted in Scotland until later. But your understanding was that there was scientific evidence that would suggest that it was important, from a behavioural scientific perspective, not to implement such measures prematurely. That was your impression at that time? My
impression at that time was that there had been discussions in those forums.
Thank you. And as regards the apparent Scottish Cabinet impression that there was a need to spread the number of cases over a long period, ideally it would be best to delay the spread of the disease into the summer months. Was there an impression at that stage that that was a goal that was achievable, extending the peak into the summer months?
So that was part of what was considered as the delay phase, where you introduce a number of non-pharmaceutical NPI interventions in order to restrict social movement and congregation. And what that does is it spreads out the peak of the expected numbers of the virus. In other words, you lengthen the period when you will have the virus, but you don't have a peak of numbers, and that goes to attempting not to overwhelm our National Health Service with cases.
So that was part of your understanding of the strategy, or part of the strategy at that time, was to spread out the peak over a longer period into the summer months was the objective. Is that right?
As long as you believed it was necessary. So it wasn't necessarily into the summer months. It was spread it so that the peak is smooth, the curve is flattened, I think is a phrase I used in Parliament. The curve is flattened so that we can cope with that. There was also the view, as I've outlined before, that the summer months, when more people are outside, transmission is lower than when we are gathered together in confined spaces.
Thank you. And the idea, I think, as we see in this paragraph, is that the anticipation was that there would be a relatively slow increase in the number of cases from the current very low base, given the efforts that are being put into containment. So there would be if one followed this practice to try to push the peak into the summer months, there would be a relatively slow increase over that period.
No, not quite. So the thinking that there would be a relatively slow increase in cases was during the containment phase, for as long as contact tracing was sufficient to contain the virus, because contact tracing is trying to capture into one place everyone who might be infected, give them the necessary advice about what they need to do so they don't infect others, and therefore contain spread in that group, if you like. But there comes a point where that isn't going to work any longer, which I think the paper refers to, at which point contact tracing isn't going to work to contain the virus. You need to take other steps.
Yes, and the document refers to, given the efforts put into containment, that there would be this relatively slow increase, I think. What efforts were being put into containment? I think we've already discussed that there weren't very many, isn't that right?
No, what we've discussed is that the efforts were around contact tracing at that point.
Yes, but what were the efforts being put into containment then?
Okay, so where cases were notified, then contact tracing contacts the individual and asks them to tell them where they have been in the most recent period. There was a change in that, I think, from where have you been from the time when your symptoms first appeared. Subsequently, it was where have you been and who have you been with from 1 or 2 days before your symptoms. Who were these people? What were you doing? And then contacting those individuals and giving them the public health advice about isolating and not contacting others.
I think we've discussed already that there were a number of limitations within the Scottish system of testing and tracing at that time. Is that right? Yes?
Yes, that's right. But it is also fair to say that with reference to the Nike conference, it was contact tracing that prevented the strains of virus prevalent in the individuals who were affected from that conference from spreading any further.
There is some comfort, I think, being taken in this paragraph from the efforts that were being put into containment. Is that right?
I'm not. No, I would have been one of the people in discussion. The following points were made. At no point in 18 months did I feel comfortable.
But in that paragraph, what's being suggested that given the efforts that are being put into containment, it's likely that over the next few months, there would be a relatively slow increase in the number of cases from the current very low base.
Yes.
So the containment efforts will result in this objective that I think we've identified as to being to try and squash the sombrero or whatever one calls it, to get the peak further into the summer. And those some reliance is being placed on those efforts as being something that makes it likely that that will be achievable. That's what it says on the page.
Yes, I mean, I absolutely. A slow increase in the number of cases from the current very low base, given the efforts. And you're right, it does say over the next few months. That was a mistake. The efforts being put into containment would not see us through the next few months because the virus was transmitting far too quickly for that. Again, to be sure that we're understanding each other, the flattening of the peak is part of the delay phase. That's the point of those non-pharmaceutical interventions, is to slow down transmission. Containment is about trying to contain it.
Thank you. I'd like to ask you, move on to a slightly different, though connected area, which comes in around this period as well, to do with the spread of COVID-19 in care settings. Mm-hmm. In particular, to be clear, I'm interested in care homes, obviously, but I'm also interested in prevention measures that were taken to try and protect people that were having care in their own home.
Yes.
So we have already established, I think, that it had been known from the minutes from at least early March, if not before, that the elderly were particularly vulnerable to the virus. That was established.
Yes.
And I think that it had been known, had it not, from sources, including the Diamond Princess episode towards the end of February, that elderly people who are put in confined spaces indoors were particularly at risk, as that episode had rather shown. Professor Sridhar, I think, described it as almost like an experiment that would show you quite a lot that one wouldn't have wished to have happened, but from which one could derive quite a lot of information. Is that a fair background to where we were, say, by the beginning of March?
Yes.
Thank you. Could I turn, please, to the Cabinet Minute from the 10th of March, which is INQ 000238-706. Just 1 second. Sorry, I've got the wrong reference. It's INQ 0000, is it 40? 78529. Sorry, my fault. This is, in fact, the Cabinet meeting from the 17th of March. Yep. If we could go to page 3, paragraph 12, please. So there's some discussion at this Cabinet meeting where it says social care presented particular problems, including those associated with residents in care homes and similar settings. COSLA had been invited to provide a coordination role across Scottish local authorities' social care services, and bodies such as Scottish Care were already working with COSLA to achieve the best outcomes for those in care. This appears from our analysis to be the first substantive recognition in Cabinet that there are particular problems associated with residents in care homes and similar settings. The Cabinet minutes contain no further consideration of these problems. Is it correct to say that around this time there was no urgency or prioritisation of the issues that would be posed for those who are in care, using that broad definition I gave a moment ago?
No, I don't believe that is correct. Guidance had been issued to care homes on the 13th of March, advising social distancing or physical distancing, visiting restrictions. I had written on the 13th of March that patients should be screened clinically to ensure that they weren't being transferred inappropriately to care homes. So this Cabinet meeting is after that guidance was issued. So I don't think it's fair to say that this is the first time consideration was being given to this situation. That had not been the case from my perspective as the Health Secretary, or indeed, I believe, from the First Minister.
Thank you. Well, we'll get on to the guidance in a second. INQ 000250859, please. This is a chain of emails from slightly earlier. If we could go to page 4, please. So there's a chain of emails here relating to contact, which it appears has happened on the 10th of March. It states this is sent on behalf of the First Minister to the CMO, and it states, the First Minister would be grateful for advice on the following issue as a matter of urgency. A friend of the First Minister whose relative is in a care home received the letter below from the home today. The First Minister said it rather makes the point that people are starting to vote with their feet, but it also begs the question of whether we need to issue some additional urgent advice to the care home sector. FM would be grateful for thoughts, advice. In fact, without going into the details, it's a letter where a care home has sent material or a notification to a relative of someone in a care home relating to issues and an escalation of preventative measures which may cause some anxiety. Is it the case that this email correspondence, which seems to have come to the First Minister from a friend, was the first indication or the first matter which provoked the need to try to issue some guidance?
No, it wasn't.
Well, when did the concern about care homes and those in care start within the Scottish Government?
So, it started most definitely in and around February. The Chief Nursing Officer was the lead official in this, given her responsibility, or the responsibility of that post for infection prevention and control. And discussions were beginning with Scottish Care and with COSLA. You'll recall, I know, that the care home sector and the care at home sector is not like our National Health Service. It is a mixed economy. Local authorities have a significant responsibility for commissioning that service and have a significant locus in that service, as does the Care Inspectorate. So consideration was being given early on about what we could do in that sector for those residents, bearing in mind this is their home, about how we could institute measures in addition to the National Manual of Infection Prevention and Control, which is part of their contract all providers are required to abide by. What else could we do that would assist them to protect their residents? And I would like to say at this point, I have said it before, but I want it read into the record here, that I was personally very concerned about our care sector, both our residential care sector and the care at home sector for adults, not all of whom were elderly, and regret very much, and will do for the rest of my life, any deaths that occurred there because of action that the Scottish Government didn't take or did take but could have done better.
Thank you. On the subject of the deaths, of course, we know that 50% of the deaths in Scotland in the first wave of the pandemic occurred in care homes.
Yes.
You mentioned the idiosyncrasies, if you like, of the way in which the care sector is organised in Scotland, not part of the public service entirely, but with a combination of public and private delivery. It is the case, however, that the threat to people in care homes which resulted in those deaths is a public health matter for which the Scottish Government had overall responsibility.
Yes, that's correct.
And which fell within your remit as Cabinet Secretary.
Yes.
When you say you were concerned in February, I think you said, about the care sector with the wide definition I've given to it, it is correct to say that despite the concern that you've indicated that you had, no guidance was issued to that sector until the 13th of March, which was after the date upon which the email was sent to the First Minister from her friend, which indicated there were concerns within the sector. Is that correct?
That's, excuse me, that's correct. Part of the difficulty that Scottish Government, we had in Scottish Government at that point was because of the devolved nature, I think it's probably fair to say, of the governance and management of that sector, the data that Scottish Government held was limited about the exact number of care homes. I believe we actually, for the first time, got the information from Dr McCaskill in Scottish Care about his membership and about the size and spread of those care homes, in other words, the number of residents they might have, their staffing levels and so on. So centrally, we had limited data, much more limited than we had about the National Health Service.
Was it not possible, we've heard evidence already about the limitations on the Scottish Government's access to data in the care sector, was it not possible to try to get some of that information from the likes of Dr McCaskill, who was engaged in the sector?
Well, as I've just said, yes, we did. And officials were actively working to get that information. And of course, Dr McCaskill and I had previously worked together before the pandemic. So it was entirely possible, and we did converse frequently over the whole period of the pandemic.
There was a particular concern, I think, from those early stages about the possibility that the transfer of patients into care homes, either from the community or more particularly from hospital settings, may pose a risk to those care homes, given that patients who are, or residents who are being transferred may have acquired the virus in another setting. Is that correct?
So there was twofold concern. One was that patients who were ready to be discharged from hospital because they no longer required hospital-based clinical treatment should not stay in hospital any longer. Now, this was a pre-COVID concern, any longer than they needed to, especially if they were elderly or frail, because a longer stay in hospital diminished their muscle capabilities, could produce confusion in those who had not previously experienced that, and so on. In terms of COVID, the concern was that that made them more vulnerable to acquiring the infection in hospital. Against that was the risk of transferring people to care homes who had not been tested. And what we attempted to do was to put in place additional mitigation measures to the National Manual on Infection Prevention and Control, which all care homes were required to follow. And those additional mitigation measures are the ones that are set out initially in the 13th of March guidance, but then increased significantly over a relatively short time scale.
The 13th of March guidance, as we've seen in documents already, you'll recall, includes guidance that there should be social distancing, essential visits only, that the homes should accept admissions to the home if safe, and that the home should be closed if residents test positive. There is no requirement in that for transfers from either the community or hospital setting to have a negative test before there is an admission. Is that correct?
No, that's correct. And that partly goes back to our earlier conversation about the availability of testing capacity.
We'll get back onto that in a second. Just as regards these particular measures, you mentioned a moment ago the possibility that residents of care homes who are patients in hospital may suffer from confusion. To what extent was there understanding within the Scottish Government about whether it would be practically possible for social distancing to take place, either as a result of patients suffering, for example, from dementia or other such conditions, and as regards the capacity and ability of care homes to enforce such social distancing in those environments?
So our understanding was that, or my understanding was, primarily through discussions with Dr. McCaskill, that it would be possible to do that, but we needed to have some flexibility, particularly around patients who are residents, I should say, who suffered from dementia, who may find the lack of communal gathering upsetting and distressing. And at some point that feeds into the visiting guidance as well.
What did the guidance mean when it referred to essential visits only?
So essential visits only referred to both end-of-life visits by family, but also those visits that might be necessary from a family member where an individual resident was distressed. It could also mean clinical visits from a local medical practitioner.
Was consideration given to the difficulty that there might be explaining that requirement to residents of care homes who may have dementia?
Well, yes, but in none of this was there a risk-free choice, in none of this, at any point. So, yes, I understood very well the difficulty and the distress that might be caused to residents, and certainly the distress to their families, by asking for physical distancing, the ending of communal dining, the ending of communal association, the ending of some of the external visits that residents do a great deal from, whether that was in terms of physical physiotherapy or local schools visiting or what it might be. So I understood that, but I also believe to allow that to continue was to increase the risk of transmission of the virus into the care home and transmission of the virus within the care home.
Did the guidance either on the 13th of March or indeed the subsequent one, which I think was dated the 26th of March, include any guidance relating to requirements to minimise the risk of infection from staff in the care homes?
So both sets of guidance, as I recall, covered the use of PPE and guidance to staff on what PPE might be required and the putting on and the taking off of PPE, particularly if as a staff member you were dealing with more than one resident. You had to take everything off and put on a new set. Clear guidance, obviously, that's in the manual, but it was repeated about hand washing and so on.
What was the Scottish Government's understanding of the availability of that PPE in order to meet those requirements?
So up until pre-COVID, care homes and the adult social care at home sector, that mix of, I think, 80% private providers, 20% local authorities, and the rest were third sector or independent providers. All of them were responsible for the provision of their own PPE and for their contracts. But Mr. McCaskill, primarily, but not only him, drew my attention to the problem that at that point some were having with sourcing PPE, because this is a global pandemic, the demand for PPE is very high, the price is soaring, and the orders that they had were pretty low value orders in terms of the amount, so they were getting squeezed. And it was at that point, I think the 19th of March, when we introduced the triage service. In other words, I decided that our national procurement service, which procured in volume PPE for our NHS would now procure PPE, additional amounts of PPE, to try and help the social care sector because it was a known provider and purchaser of PPE. It did it in high volume. It had known suppliers who would want to continue to be suppliers post the pandemic. So the chances of being knocked off the list, if you like, or pushed down the list for delivery was lower. And they had the strength, if you like, to increase their PPE volume so that we could begin to offer it, not just to the social care sector, but also to primary care in the community, including our pharmacies and so on.
That initiative was instigated on the 19th of March, did you say? And that will have taken some time to start to feed PPE into the system, because there would need to be negotiations about availability. Although, of course, you say that the Scottish Government is using its purchasing power, it would be necessary to actually procure that, as you say, in a global pandemic.
No, NSS, so our national services, which is the procurement arm of the NHS in Scotland, had stockpiles of PPE. And so introducing that on the 19th of March meant that they could provide from their stockpiles PPE to care homes, and that triage service. Now, as we subsequently see, it was changed later because it was a reactive service, so it relied on care homes to ask for what they needed. But the national, or NSS, the procurement arm, could already provide from its stockpile. What it then had to do was increase its orders coming in order to keep the stockpile at the level that was needed.
As at the date of the 13th of March guidance, I think you've described that the guidance pointed out that PPE would be necessary for staff in order to minimise the risk of infection, how it should be used in order to try to achieve that aim. So the requirement for it was known, but as far as the guidance was concerned, the position at that date was you're on your own.
I wouldn't put it as bluntly as that, Mr Dawson, because that implies a careless attitude on my part or anyone else's, and we certainly didn't have that. What that reflects is the pre-pandemic position. And as soon as it was made clear to me that that pre-pandemic position was struggling to produce the level of PPE in the quantity or of the type that was required, by Dr McCaskill and others, then we acted to change that so that the National Procurement Service for the NHS could provide PPE to our care sector, both adult social care at home, but also residential care.
I wonder if I could draw your attention to an email which was received, as I understand it, by Scottish Care from one of its members on the date of the 25th of March 2020. It's INQ 000249952. This email, as I say, dated the 25th of March, sets out a number of the issues which one of the members of Scottish Care is having at that time. Now, we've looked at this before, but I'd particularly like to take you to the passage under the slightly understated comment, a few worrying points just below where we are at the moment. And over to the next page, please. So this is what this particular care home is being told. And just over to the next page, it says, as long as staff wear the appropriate PPE, which is effectively a shorthand for that element of the guidance. It says that's not possible. No care home has the appropriate equipment, none. A low-grade face mask, a plastic apron, a pair of latex gloves is not the appropriate equipment for barrier nursing a potential carrier transferred from a high-risk area in the middle of a deadly, highly contagious pandemic by a care assistant with no training in high-risk infectious diseases in a care home not equipped or designed for such. Does that, Ms. Freeman, adequately explain the difficulties that were being experienced with the guidance, the difficulties that were being experienced with PPE, and frankly, the completely unrealistic expectation of the Scottish Government as regards this particular sector and the risk to the residents of care homes?
I think what it tells us is that there were serious issues being raised that needed to be taken seriously. PPE guidance did not come. I did not write PPE guidance for the very reasons we've touched on before. PPE guidance came through our Chief Nursing Officer Directorate based on their clinical understanding of infection prevention and control, informed by all the emerging and constantly emerging information about the nature of the virus. So PPE guidance changed over time, and the guidance that would have been in that issued on those various dates reflects the advice that I was being given about the kind of PPE that was needed. Now, there were instances raised with me, not least in terms of care at home, about PPE and A, the availability of it, and B, the lack of allowing those care at home staff to exercise their professional judgment about what they needed, that I sought to resolve, and sought to resolve quickly. But wherever issues were raised, whether they were directly with me, whether it was through the PPE helpline, whether it came from Dr. McCaskill through his members or any other route, then my response was to double check what the concern was, and if there was a problem in terms of receiving PPE or the adequacy of PPE, to try and resolve that.
But these are more than just simple practical issues. This is an indication which has been presented by Dr. McCaskill in his evidence, as I understand it, accepted this was from one care home but representative of problems experienced across the sector, that it was simply not possible, as it says here, for that type of system to be instituted within a care home, which of course is not the same as a hospital.
No, it is not. It is a resident's home. But what was not being suggested to me at that point from Dr. McCaskill or anyone else was an alternative to those mitigating measures that I had to put in place until our testing capacity increased to the level that we could undertake testing prior to discharge or admission to care homes.
Another consequence of the policies, the guidance, which Dr. McCaskill, of Scottish Care, pointed out in his evidence, was that the 13th of March guidance caused confusion within the care sector, which led to the belief that individual residents who were COVID-19 positive should not be transferred to hospitals. He talked of a presumption of a blanket ban on care homes transferring residents who had tested positive to hospitals, which meant that they were unable to access required medical care. Was this an issue that was brought to your attention?
It was, and I believe our CMO acted on that. And having read the guidance, I can understand why that concern was raised. What was intended, as I understood it, by the particular paragraph was that, as I have recently experienced indeed, it is not always appropriate for an elderly person who is seriously ill to be transferred to hospital where the risk of that transfer increases to their health than to be provided care in their own home. That's what that paragraph intended to convey. The manner in which it is written, I can see why it would be taken precisely as people were concerned.
What did you do in response as regards that particular aspect of the guidance?
So I asked our CMO, first of all, to describe to me what was meant by that, and then to make sure through her channels and her reach that it was clear what was intended by that it was a clinical judgment whether an individual should be transferred from any setting into hospital, just as it is a clinical judgment whether or not an individual is ready for discharge. It's not for anyone else to make those judgments.
To be clear, you're referring on a number of occasions to advice from the CMO, the Chief Nursing Officer. Ultimately, you and the Scottish Government are responsible for the guidance. Do you accept that?
I do. I have never cavilled from that in any respect. I was the Cabinet Secretary for Health,
Yes.
so I am and was responsible.
Thank you. We understand from his evidence again that you met with Dr Macaskill on the 18th of March.
Yes, I did.
Could I have a look, please, at INQ 000261341, page 2, and I'd like to address the testing aspect. Just before we go to the text, just to clarify, I've read out to you the provisions, the broad provisions of the 13th of March guidance. And is it correct to say that neither the 13th of March nor the 26th of March guidance contained any requirement for there to be a negative test, or indeed more than one negative test, before a patient was moved from a care home, from a hospital into a care home?
That's correct. The 26th of March guidance introduced the isolation period, and I think Dr Macaskill refers to the aspect of it which is 7 days. Yes. In what we're about to look at.
Well, I simply want to confirm with you that the guidance did not require there to be negative tests before hospital discharge, and indeed no test was required for admission to a care home from community either.
That's correct.
That changed subsequently in the 21st of April guidance,
Yes.
where there was a requirement, in fact, for 2 negative tests. Is that right? Just to put this into context.
Yes, that's correct.
Thank you. So to look at this document, please. This is a document that was prepared for you, a briefing in advance of the meeting that you attended with Dr Macaskill. And in this, it is stated under testing, they have concerns regarding the current testing arrangements and would like people tested before they are discharged from hospital to care homes, so that care homes feel confident in accepting admissions from hospitals, and testing for frontline social care staff in order to avoid 14-day isolation period ends to enable them to return quickly to work. Then it says lines to take and outlines various options relating to testing for patients. People is currently being triaged into 4 different categories. Testing for staff, currently neither health or social care staff are being tested unless they fall in categories 1 or 2 above. And if we could turn then to page 2, paragraph 11, please. It's the passage starting, if our aim. Maybe over the page. Sorry, just 1 second. Maybe a different document. Sorry, it's a different document I'd like to go to, if I could. It's INQ 000222973. So this is a different paper, which is prepared by Mr. Grieve, in fact, for Nicola Sturgeon and you on the 18th of March, so the same day. So it's putting in some context. We've seen already that a meeting is being set up. There are a number of things which are going to be discussed. Various options are presented. And on page 2, paragraph 11, sorry. It says, if our aim is ultimately to contribute to saving lives, then we will not be able to limit testing to hospitals. A substantial proportion of those who are likely to be infected by the virus will remain in a community setting, in particular care homes. Colleagues in HBS are currently modelling this demand. What we know is that there are 35,989 residents in 1,142 care homes. Testing a significant proportion of all of these residents would significantly exceed the available capacity in laboratories. This paragraph starts with the conditional, if our aim is ultimately to contribute to saving lives. Can we take it that that was the aim of this?
It absolutely was. I have no idea why Mr. Grieve would put if in that sentence.
Care home residence has, of course, been assessed as high risk from early on in the period that we've been looking at. Is that correct?
Yes.
And as far as this is concerned, it seems to identify that lives will be lost if more is not done. Is that correct?
Yes.
And that the issue, the sole issue at this stage, is testing capacity. Is that right?
The primary issue at that stage
Right.
is testing capacity, yes.
And as we said earlier, testing capacity is something that effort could have been put into at an earlier stage in order to try and ramp it up beyond the levels we discussed. It could have happened at an earlier stage.
I'm not sure I agree with you. You cannot magic out of thin air appropriate buildings, appropriate kit and skilled individuals. A lot of effort was put into increasing our capacity for testing, because even if I hadn't understood the vulnerabilities in our care homes and other closed settings, I understood the vulnerabilities of those caring for individuals in terms not only of PPE, but of knowing whether or not they were themselves infectious and posing a risk not only to themselves, their families, but also to those they cared for. And I believe that we moved as quickly as we could, actually could, to increase our testing capacity. And it has never been put to me that there was testing capacity available somewhere else that we could have used and didn't use. We did our very best to increase that, and of course managed in the end to do that. And as you've noted, we will sure come on to it, in April, we were able to introduce testing for admissions. But the whole issue of transmission and health and death in care homes is a complex issue. If I can just make the point, and even at that point from Mr. Grieve, his known number of care homes is inaccurate. There actually were 1,084 care homes. 843 of them had discharges from hospital. 348 of those had outbreaks. 321 had deaths of those who took discharges from hospital. What that tells us is that some care homes that received discharges from hospital during this time did not have outbreaks, because the issue is a complex one. Not complex in terms of the professionalism, the commitment or the care of care home staff, but complex, as a subsequent independent report also reveals, in terms of size of care home, as well as the availability of PPE and so on. I am not, and I need to be clear, I am not saying that the discharge from hospital without a test into care homes had no impact. What I am saying is that it was one of the factors. And I think Public Health Scotland witness that you had before you previously, my lady, said that it was, but actually in their analysis and the independent analysis, the size of the care home was a more significant factor. So this is a complex issue that testing on its own does not help us understand as well as we need to.
The figure given to you there, that there were 35,989 residents in care homes, what's the relevance of that figure to your assessment at the time?
That we were worrying about a great number of people who were residents in care homes and who, because of, for many, not all, but for the vast majority, because of their age, their frailty, other conditions they might have, were vulnerable to this virus.
You do not know, or did not know at the time, the number of patients, not the total number of residents, but the number of patients who would be transferred from hospital to care homes, did you?
No.
That was the relevant figure that you needed in order to be able to ascertain how many tests you would need.
No, not necessarily, because I would also want to know that people who were being discharged into the community had also been tested.
But in order to try to, well, you'd need to know that figure too, but in order to try and work out the issue of the number of tests that would be required for people who are coming from hospitals, this is the topic that we're discussing, you would need to know the figure of transfers, not the total number of residents. Isn't that right?
That's right. Yeah.
We know already from other evidence that you did not have access to that information. Did you seek to try to understand the numbers that might be involved, for example, from Dr. McCaskill?
I can't recall if I had that conversation with him. We talked a lot about discharges and admissions to care homes, but I can't recall if he gave me that number or if we discussed a number.
We heard some evidence from an individual you would be familiar with, Caroline Lamb, who told us that there was a degree of prioritisation of tests within the test and protect strategy. But she said that she was not involved in the prioritisation discussions for the testing around this time. Were you responsible for deciding who should be prioritised for tests?
No, that was a clinical decision, as it should be, and in the early days, the prioritisation was to assist with diagnosis, and there were two other categories. I can't quite recall. I'm sure you have them.
So when you say it was a clinical decision, do you mean that that was a decision you made based on clinical advice from the Chief Medical Officer? And perhaps others?
Yes.
So a prioritisation was given to people other than the residents of care homes who might have been tested, even although it was known that the residents of care homes were within the highest risk category.
Admissions of elderly people to hospitals would also be in that high-risk category, and testing them in order to diagnose what needed to be done, but also to identify if they had the virus and protect other patients by appropriate pathways for the individual was also a priority.
You've referred already to the fact that the strategy changed in April.
Yes.
We understand that a deep dive meeting into care took place on the 15th of April. There's a reference to that in one of the SCORE sit-reps. You might remember those documents that provide a lot of information. What was it that prompted the deep dive meeting to happen on the 14th of April?
So by that time, we had introduced testing for all health and social care staff. And those that we were seeking to return back, perhaps individuals who'd retired or those final year medical or nursing students, to ensure that they were tested. We'd also introduced a situation or a requirement that all symptomatic residents were tested where that was appropriate. Bear in mind, at this point, the test was both you had to swab both the nose and the back of the throat. So for some individuals, that was a very distressing experience, and that's what if appropriate meant. Mm-hmm. The deep dive at that point in April was around bringing together all the information we had about what we were doing, what more needed to be done, whether we were able to do it, and then focus the actions around that.
Was the deep dive meeting indicative of a realisation in the Scottish Government that insufficient efforts had been made to protect those in care homes and many, many residents had died?
There was certainly a realisation of that, but that realisation didn't suddenly happen on the 15th of April. I don't think the 15th of April was a sudden dawning on the part of Scottish Government, Scottish ministers, myself or the First Minister, that this was a serious issue. I think I've explained that for some weeks this had been considered by me as a very serious issue. But we were now at a point where it might be possible that our testing capacity was such that we could add that additional measure. It was also a realisation or a growing understanding that the understanding and application of basic infection prevention and control was not necessarily consistent across all residential settings. Again, to be very clear, that is not a criticism by me of any member of staff, but it is the case that in some instances, as the figures I gave you earlier indicate, some of our care homes were responding to the guidance more fully than others for a variety of reasons that we sought to understand through discussions with Dr. McCaskill or individually with some of the providers, and sought to try and help support them to do that.
Despite that background, the additional measures didn't come in until the 21st of April, that's correct?
That's correct.
Those, we've talked about the testing element, which as I understand it is based on a lack of availability of testing until that time. That's why that changed, is that right?
Yes.
As other elements of that guidance included increased oversight in order to try to make sure that the various measures that were required within care homes could be carried out properly. Is there any reason why that oversight could not have been put in place much earlier? Until
that point, or until the period running up to that point, I think I mentioned earlier that Scottish Government's knowledge of and complete understanding of how the adult social care sector operated was not as adequate at the outset as we needed it to be. And so there were some presumptions made that as we worked through the days became clear could not stand. One of the presumptions that I made, and I regret this, is that the National Manual for Basic Infection Prevention and Control was widely understood and practised. I think, again, for reasons I've indicated and with no criticism at all of individual staff, that was not consistently the case. Some other areas of our understanding of particularly the care at home sector was not adequate at the outset. And so we had to work through, with Scottish Care of course, but also with COSLA, to increase our understanding and identify the deficiencies in how the system was operating. And one of those deficiencies required greater clinical support to the care home setting. Hence, that part of the guidance that requires directors of public health, each health board has a director of public health, to take a direct engagement with the care homes in their area to look at what more support might be needed.
As had been the case in the early months of the pandemic, Ms Freeman, the Scottish Government's response to the care home crisis and the need for people who are vulnerable and elderly to be protected was completely inadequate, was it not?
It was not as adequate as I would have wished it to be. I believe it was all that could be done with the resources available to us at that point, and that improved as time passed.
Thank you. Those are my questions. As I understand it, there are some pre-roll tents. Thank you, Milady.
Ms Mitchell.
And for asking many questions the Scottish Covid Bereaved wish to have answered. I appear as instructed by Amar Anwar and Company on behalf of the Scottish Covid Bereaved. I'd like to ask you please about communication strategy within Scottish Government. In particular, misinformation was an important issue in the pandemic, particularly with the prevalence of people getting information from social media, which couldn't be properly regulated. The current First Minister's written evidence has been submitted before this inquiry states the Scottish Government did not directly refute misinformation, but instead worked to ensure our own factually correct messages were communicated widely. What I would like to know, first of all, was this a tactical decision taken by the Scottish Government not to refute misinformation in relation to issues during the pandemic? And secondly, if so, what were the reasons for that tactical decision?
So the principal reason for not directly refuting in that through social media, if you like, misinformation was really to avoid getting into a he said, she said situation. But for example, in the care sector, there was a lot of concern and anxiety around what was misinformation, for example, about vaccines. And so rather than have a social media argument about that, with the support of Scottish Care, we set up a series of webinars which simply allowed staff to ask questions that they had, concerns that they had. They may have received information that was wrong. They may have just straightforward concerns about vaccine efficacy. Around the speed with which vaccines were produced, people had some concerns about whether they were as safe as pre-COVID. And that was the approach that we took to dealing with misinformation, was simply to try and find opportunities where people could ask questions about their concerns, that we could answer those questions directly to them. And webinars were used a great deal by Scottish Care and ourselves, or open meetings with trade union members where they could, through Zoom or whatever it might be, ask a number of questions, rather than have a social media or any kind of media tit-for-tat argument, which I don't think would have served anybody particularly well.
I'll move on to my next question. The inquiry has already heard evidence given by the First Minister, then Minister or Cabinet Secretary for Health, and Mr Swinney, who is still to give evidence, met with the Scottish COVID bereaved on the 17th August 2021. At that meeting, members of the group expressed their concerns about the classification of the 3 cardinal symptoms of COVID: cough, temperature, and the loss of the sense of smell and taste. Their concern was that these 3 cardinal symptoms were too restrictive, and they were raising that to see whether or not anything could be addressed. Were you aware of the concerns raised by the Scottish COVID bereaved in this regard?
Well, of course, in August 2021, I was no longer an MSP or in government, but I recall from rereading the guidance in preparation for today and for my witness statement that there is, and I can't be certain whether it begins with the first guidance or whether it appears in the second, but there are sections which remind the reader that in elderly people, the symptoms may be different. They may manifest themselves in a different way. That could be increased confusion, it could be more falls. So we were alert to the fact that the standard symptoms, that you shouldn't confine yourself to saying, well, that person hasn't got a cough and their sense of smell's fine, so they must be all right, something else happening. You needed to think more widely, particularly if you were dealing with elderly or frail people.
Did you play any part in considering the issue of COVID symptoms, for example, in discussions with the CMO or Mr McCaskill or anything of that nature? Did you discuss with them the cardinal symptoms and whether or not they should be expanded?
I do recall, I believe, discussions with Mr McCaskill because he wanted to ensure that the guidance took account of that. I don't recall particular discussions with the CMO on that, although we did have discussions about the symptoms that we were alerting the general public to, because I think, in fact, I'm sure, the list changed at one point during the pandemic. A new one was introduced.
Indeed, and I think when we were asking questions of a witness before, the inquiry has evidence that that is the case in 2021, that they changed. And indeed, the inquiry has also heard evidence from Mr McCaskill about the issue of the difference in symptoms that were being identified as COVID symptoms, but they were different and not manifesting in the same way in a population which was older with multiple comorbidities. He says that was aware to him late February and certainly early March 2020, but a change didn't occur to 2021. Can you tell me, if he raised this with you, why it took so long for changes to be considered?
So, well, before 2021, as I've already said, the guidance that was issued to the care sector did mention this and did raise to be alert that the standard COVID symptoms, if you like, may not manifest themselves in elderly or frail people, and they had to look otherwise.
That was June 2020. And then the actual symptoms were a year later. But in those early days, was there any consideration given to changing, as it were, those symptoms and advice?
So the symptoms of COVID, from memory, came to us from the 4CMO discussions. And I don't think, I certainly didn't feel competent to question whether it was a cough or not a cough, or a sense of smell or whatever. But I did discuss with Mr McCaskill prior to June 2020, and I believe the guidance prior to June 2020 did mention that for those who were elderly, you had to look beyond the standard symptoms that were being advised to the wider public.
Milady, those are my questions.
Thank you very much, Ms Mitchell. I think that completes the evidence for today. Mr Dawson, thank you very much, Ms Freeman. I appreciate I've asked you to attend twice now. I'm not sure I can say I won't ask you again. So
No, I understand.
Thank you very much for your help.
My lady, if I may just take this opportunity to apologise. The last time I did attend, I did so virtually, and we had some internet issues. And I just, for the sake of my colleagues at the University of Glasgow, I need to be clear that was not their fault.
Right. I think someone was blaming Scotland rather than Glasgow.
I don't think it was the country's fault either, but it
Well,
was
exactly.
certainly the internet.
I didn't think it was the country's fault.
Thank you very much.
Thank you. 10 o'clock tomorrow, please.
Thank you, lady.